Okay, imagine this. You've got this nagging hip pain. It just won't quit, and you're starting to think, maybe this isn't just a pulled muscle. What if that pain, that sort of everyday discomfort, was actually a warning sign, a sign that the bone in your hip, the very top of your thigh bone, is losing its blood supply and, well, dying? Welcome to the Deep Dive. Today, we're getting into something called Avascular Necrosis of the Femoral Head. AVN is the short version and also the conditions that can look a lot like it, which is tricky. Our mission here is basically to give you, the listener, a shortcut. We want you to be really well informed about this condition. It's often misunderstood. We'll look at what causes it, how doctors figure it out, especially using imaging. That's key, what the treatments are, and crucially, how they tell it apart from other things that feel similar. And just so you know, everything we're discussing, it comes from a really thorough, up-to-date review article. It's just published early 2025 in the Indian Journal of Musculoskeletal Radiology. So this is current expert thinking. All right, let's unpack this. When we say osteonecrosis or avascular necrosis, what are we actually talking about?
Right. So osteonecrosis basically is bone tissue dying off because it doesn't get enough blood. Think of it as ischemic bone death. When that blood flow stops, the bone cells just can't survive. And down the line, the bone structure can actually collapse.
Okay, so osteonecrosis is the general term. How is AVN different?
AVN, or avascular necrosis, usually refers to this happening right near a joint in the weight-bearing areas, like the ball part of your hip joint, the femoral head. That's a classic spot. Bone infarcts are similar, ischemia again, but they tend to happen a bit deeper inside the bone, more in the shaft or the marrow cavity and not right at the joint surface.
And why is AVN such a big deal when it hits the femoral head? It sounds like it could cause more problems than just some dead bone.
Oh, absolutely. What's really significant here is how AVN in the femoral head can escalate quite quickly. It starts as a localized bone problem, sure, but if it progresses, you can get what's called articular collapse. The smooth surface of the joint literally caves in, and suddenly it's not just a bone issue anymore, it's wrecking the function of your whole hip joint.
Wow. And it doesn't always stop at one hip, does it?
That's a critical point, yeah. Around 50%, half of patients with AVN in one hip will end up developing it in the other hip, usually within about 2 years.
50%? Seriously? So checking both sides is standard practice then?
It has to be. And if you see osteonecrosis in, say, 3 or more different joints, we call that multifocal osteonecrosis, it really points towards something systemic going on, maybe an autoimmune issue or some kind of metabolic disorder affecting the whole body.
Right, it's a clue to look deeper.
Exactly. And we've actually seen a noticeable increase in cases recently, particularly in the Indian subcontinent post-COVID. It seems linked to the heavy use of steroids during the pandemic.
That's concerning. It just highlights the need for awareness.
It really does. And the femoral head itself, it's just particularly vulnerable. It has what we call precarious blood supply. It's not very robust to begin with. Plus, it takes a huge amount of load whenever you're standing or walking.
So a vulnerable spot with a tricky blood supply. Okay, so how does the blood actually get cut off? The source mentions 2 main ways, right?
That's right. 2 main mechanisms. The first one is pretty straightforward. Direct damage or blockage of the blood vessels themselves. So things like thrombosis, blood clots forming in those tiny arteries, or maybe vasculitis, where the vessel walls get inflamed. Either way, the pipe gets blocked or damaged.
Okay, so the plumbing's directly affected. What's the second way?
The second way is about pressure. You have to think of the inside of the bone, the marrow space, as a closed box, basically. If something causes swelling in there, maybe extra fluid, or an increase in fat cells, which can happen with steroid use, for example, the pressure inside that bony box goes up.
Ah, I see, like inflating a balloon inside a widget container.
Exactly, and that rising pressure physically squeezes the small, delicate blood vessels running through the marrow. It compresses them, cuts off blood flow, starves the cells of oxygen, and you get cell death, ischemia.
So it's not always a direct blockage. Sometimes it's just internal pressure squeezing the life out of the supply lines. That makes a lot of sense, especially for the femoral head being so enclosed. And a fracture, like a break in the femoral neck, that's a clear example of the first mechanism, right? Physical damage?
Yes, a femoral neck fracture is a classic example of traumatic disruption of those critical vessels. It physically tears or damages the arteries supplying the head. Understanding both mechanisms, direct vessel damage and increased pressure, is really key. It helps doctors figure out who's at risk, and it guides how they might try to treat it, how to potentially save the bone.
Okay, finding the clues. This is where it gets super interesting, especially for diagnosis. How do doctors actually see this problem, especially if someone doesn't even have pain yet?
That's a great point. Early AVN is often silent. Pain usually comes later, sometimes only when significant damage has already occurred. So imaging is absolutely critical. It's essential for catching it early, which then helps decide on treatment, predict how things might go, and track whether the treatment is working.
So we're looking for invisible damage, essentially. What's the first imaging step? Usually x-rays, I assume.
Yeah, standard x-rays or radiographs are typically the first port of call. But, and this is a big but, they have major limitations for early AVN. You often won't see any changes on an X-ray for maybe up to 3 months after the blood supply is compromised. Early signs like subtle bone-thinning osteopenia are really easy to miss.
So not very sensitive early on. What signs do show up later on X-ray?
As it progresses, you might start seeing patchy areas of sclerosis. That's where the bone looks denser. It's reactive bone trying to form. And then there's the crescent sign.
The crescent sign. You mentioned that. Sounds significant.
It's a really critical finding, yeah. It looks like a thin, curved line just underneath the cartilage surface of the femoral head. What it actually represents is a subchondral fracture, a tiny break in the dead bone that's starting to collapse under pressure. It's a clear sign of structural failure beginning.
Okay, a bad sign. And you need specific views.
Definitely. Getting both a standard front view, AP view, and a frog leg lateral view where the leg is bent and turned out is important to maximize the chances of spotting these changes.
All right, so x-rays are a start, but maybe not enough for early detection. What about CT scans?
CT, computed tomography, gives much better detail of the bone structure itself. It's good for seeing the exact extent of the dead bone, picking up those subchondral fractures, and seeing if the internal meshwork of the bone, the trabeculae, is disrupted. But like X-rays, CT isn't great at seeing the very early changes within the bone marrow, like edema or swelling. That's where MRI shines.
So CT is better for bone detail later on, but still not the first choice for early AVN.
Generally, no. It might show advanced changes like head collapse, irregular dense areas, bone spurs, maybe narrowing of the joint space later on. Sometimes AVN gets picked up accidentally on a CT scan done for something else in the pelvis or abdomen.
Okay, so if there's one thing for you, the listener, to take away about imaging AVN, it sounds like this is it. MRI, magnetic resonance imaging. That's the gold standard, right?
Absolutely, hands down. MRI is the modality of choice. It's far more sensitive than X-rays or CT for detecting AVN early, often weeks or months before other scans show anything, and even before symptoms start sometimes.
Why is it so much better? What does it see?
It's brilliant at visualizing the bone marrow itself. We use different MRI sequences, like T1-weighted images, which are great for showing the normal fatty marrow and identifying the area of dead bone, often as a distinct line that's dark on T1. Then we use fluid-sensitive sequences, like T2 with fat suppression or SDR. These are excellent for picking up bone marrow edema swelling, which shows up bright. They also highlight joint fluid and inflammation.
And are there specific signs on MRI that really point to AVN, like a smoking gun?
Yes, there are hallmark features. The most classic one is probably the double line sign. On those fluid-sensitive images, you see this distinct border around the dead bone. It looks like 2 lines. An inner bright line, which is thought to be granulation tissue of the body trying to heal, and an outer dark line, which is sclerotic, hardened bone, or fibrous tissue. Seeing that, it's seen in like 80–85% of cases, very suggestive of AVN.
Wow, the double line sign.
Okay.
What else? You mentioned edema, BME.
Right, bone marrow edema or BM. It shows up bright on those fluid-sensitive sequences. Now, BME itself isn't specific only to AVN. You can see it in other conditions too. But when you see significant BME in or around an area that looks like AVN, it's strongly associated with the patient having hip pain, and it indicates a much higher risk of the femoral head collapsing.
Yeah.
There's a very strong statistical link there, p less than 0.00001, which is highly significant.
So edema means trouble brewing, basically, higher risk.
Pretty much. It suggests inflammation and stress in the bone. MRI can also show other things, like a reactive interface line, another type of border around the dead zone, or even signs of the cartilage and bones starting to fragment, the rim sign.
And you look at it from different angles.
Oh yeah. Coronal views slicing front to back are usually the main ones, but axial, top-down, and sagittal side views give extra detail, helping us see the exact location and size of the lesion, any early flattening or subtle fractures.
There are even more advanced MRI techniques mentioned.
Briefly, yes. Things like chemical shift imaging can help differentiate marrow types. Perfusion imaging, like DCE MRI, actually looks at blood flow and vascularity, giving functional information which can be really useful, especially for telling AVN apart from some mimics. Diffusion imaging can sometimes pick up very very early changes too, but it has limitations.
Okay, fascinating stuff. What about that other one, radionuclide scintigraphy? Bone scans, where do they fit in?
Bone scans, yeah. They involve injecting a radioactive tracer. Very early on in AVN, you might see a cold spot, an area with no tracer uptake because there's no blood flow. Later, as the body tries to repair things, you often see increased uptake, a hot spot. They're more sensitive than X-rays in the early stages, but definitely less sensitive and less specific than MRI. Their main role might be if you suspect AVN in multiple joints, because you can scan the whole body or large areas at once relatively easily.
Right. Now, it's not always straightforward, is it? Like the relationship between that bone marrow edema, BME, and AVN itself. There was some debate there.
Yeah, there was. For a while, people thought maybe BME was one of the very first signs of AVN developing. But the current understanding, based on the evidence, has shifted a bit. It seems BME is more often a marker of advanced AVN. It tends to appear after you can already see that characteristic band-like line indicating the dead bone on MRI.
So seeing BME isn't the earliest sign, but rather suggests things are further along? Why does that distinction matter so much?
It matters because the presence and extent of BME in AVN correlate strongly with things like existing microfractures under the cartilage, with the severity of the pain the patient feels, and generally it signals a poorer prognosis, a higher likelihood of collapse. It tells the clinician the situation is more critical.
Okay, that's a really important nuance. Now, to try and standardize all this, doctors use classification systems, right, to grade how severe it is.
Exactly. There are several systems out there, but their main purpose is to stage the disease, figure out how advanced it is, which helps guide treatment decisions and predict outcomes.
Which one is the most commonly used?
The modified FICAT and Arlet staging system is probably the most widely used globally. It combines clinical symptoms like pain, stiffness, limp with findings on X-ray and MRI. It categorizes AVN into stages, from stage 0, normal X-ray, maybe early MRI signs, up to stage 4, severe collapse and arthritis. It incorporates things like the crescent sign, the double line sign, BME, and eventually cortical collapse and degenerative changes.
And it helps everyone speak the same language about the stage.
Precisely. And a good practical tip mentioned in the source is to add quantification adjectives, like saying stage 2 with 40% femoral head involvement. That gives even more useful information about the lesion size.
Makes sense. There are other systems too, right? Like Steinberg, ARCO.
Yes, several others exist. Steinberg focuses more on lesion size. ARCO looks at the area involved in collapse. The Japanese system considers the location on the femoral head. Mitchell's looks at the MRI signal characteristics within the dead zone. There's also a quantitative measure called the modified Kerboul angle or combined necrotic angle. This uses MRI to measure the arc or angle of the dead bone segment. A larger angle, say over 240 degrees, indicates a very high risk of collapse.
Okay, lots of ways to measure and stage it. Let's switch gears a bit. What actually causes AVN? And what happens to someone once they're diagnosed?
The causes are quite diverse. Trauma is a big one. We mentioned femoral neck fractures damaging blood supply. That's pretty direct. But many causes are non-traumatic, often systemic. Sickle cell disease is a known cause. The abnormal cells can block small vessels. Corticosteroid use, taking steroids for other conditions like asthma or autoimmune diseases, is a major risk factor. And chronic heavy alcohol use is another common one.
Steroids and alcohol. Those seem to come up a lot.
They do. And steroid-induced AVN is often bilateral, both hips and sometimes multifocal, affecting other joints too. The mechanism might involve fat cells building up in the marrow, increasing pressure, or maybe tiny fat emboli blocking vessels. Other causes include things like Gaucher's disease, a metabolic disorder, sometimes infections like tuberculosis, autoimmune diseases like lupus, even leukemia can be associated with it.
So a really wide range of potential triggers. Once AVN starts, what's the usual course? Does it get better on its own?
Spontaneous healing or revascularization is pretty rare, unfortunately. The usual natural history is progression. The dead bone gradually weakens, the head starts to flatten, then it collapses more significantly, and eventually you develop secondary osteoarthritis, wear and tear arthritis in the hip joint because the mechanics are all wrong.
Are there signs that predict how quickly this might happen?
Yes, certain features give us clues. For instance, having large cystic lesions, fluid-filled holes within the dead bone is generally a bad sign, associated with higher failure rates if they try certain surgeries. And the size of the lesion is critical. If more than 50% of the weight-bearing surface of the femoral head is involved, that generally means a poor prognosis and a high risk of collapse relatively soon. Conversely, sometimes extensive sclerosis, dense bone, might suggest it's trying to stabilize, though that's complex.
Okay, so early detection is crucial to try and intervene. What are the management strategies? What can be done?
It really depends on the stage. For early stages, typically FICAT stage 0, 1, or maybe 2, before there's significant collapse, the approach is often non-operative or conservative first. This involves managing symptoms and trying to halt progression. So medications might include bisphosphonates, which aim to slow bone breakdown, potentially anticoagulants or statins depending on the suspected cause, and definitely pain relief meds.
And modifying activity.
Absolutely. Reducing weight bearing on the affected hip is key, so using crutches or a walker. Physical therapy is also important to maintain range of motion and muscle strength around the hip.
And if conservative measures aren't enough, or if it's diagnosed later?
Then we move towards operative options. If the femoral head shape is still relatively preserved, the goal might be femoral head-sparing surgery. The most common is core decompression.
Core decompression, what does that involve?
It involves drilling one or several small channels into the femoral head through the dead bone area. The idea is twofold. Firstly, to relieve that high intramedullary pressure we talked about, and secondly, to create channels that might stimulate new blood vessel growth and healing. Sometimes this is done along with bone grafting, packing the channels with bone graft material, maybe even stem cells, to provide structural support and encourage regeneration.
Does that work well?
It can be effective in relieving pain and delaying collapse in carefully selected patients, especially in earlier stages. Some studies suggest combining core decompression with bisphosphonate therapy might be more effective than either one alone. Another head-sparing option, though less common now, is an osteotomy, where they cut and realign the bone to shift weight off the dead area.
And for the later stages when the head is already collapsed?
Once significant collapse or arthritis has set in, head-sparing options are usually off the table. Then the solution becomes hip replacement surgery. Depending on the patient's age, activity level, and the condition of the hip socket, this might be a hemiarthroplasty replacing just the ball, femoral head, or, more commonly now, a total hip replacement, replacing both the ball and the socket.
And after surgery, particularly something like core decompression, how do doctors check if it worked?
MRI is again very useful for follow-up. After core decompression, seeing a significant reduction in that bone marrow edema on a follow-up MRI usually correlates well with the patient feeling less pain and having a better clinical outcome. But you have to wait a bit. Getting an MRI too soon after surgery can be confusing because of normal post-operative inflammation and healing changes. Usually, if a follow-up MRI is needed, it's done maybe 6 months or more down the line.
When you watch for complications.
Of course. As with any surgery, there's a risk of complications like infection, fracture, or continued progression of the AVN despite the procedure. Careful monitoring is key.
Okay, now this is where it gets really, really tricky. For patients, for doctors, everyone. You have hip pain, maybe a limp. It sounds like AVN, looks like AVN maybe on initial glance, but it's not. What are these conditions, these mimics that can fool you?
This is such a crucial part of the diagnostic puzzle. Getting the diagnosis right is paramount because, as you say, the treatments and the outcomes for these mimics can be totally different from AVN. You don't want to do a core decompression on something that isn't AVN.
Right. So give us the rundown. What are the main culprits that pretend to be AVN?
Okay, first up, we have stress injuries or stress fractures. These result from repetitive loading or stress that overwhelms the bone's ability to repair itself. Think overuse in athletes or military recruits. On MRI, you'll often see bone marrow edema, definitely, but usually in characteristic locations like the inner side of the femoral neck or sometimes the roof of the hip socket. You might also see swelling in the muscles nearby.
And the key difference from AVN?
The key is the absence of that specific well-defined serpentine T1 dark line or the double line sign that signals true AVN, true dead bone. You see edema, maybe a fuzzy fracture line, but not the classic AVN pattern.
Okay, so stress, injury, edema, maybe a fracture line, but no AVN band. What's next?
Next is bone marrow edema syndrome. This is kind of an umbrella term, and it includes things like transient osteoporosis of the hip, TOH. This typically presents as sudden, severe hip pain, often for no obvious reason. It's notably common during pregnancy, especially the third trimester or sometimes in middle-aged men. The hallmark is intense, widespread bone marrow edema throughout the femoral head, sometimes neck, on MRI.
But it's transient, right? It goes away.
Exactly. That's the key differentiator. With protected weight bearing, the edema and symptoms typically resolve completely over several months, usually 6 to 9 months. Follow-up MRI will show normalization. Again, you don't see the focal band-like lesion of AVN. It's thought to be related to tiny subchondral fractures, but the bone isn't actually dead.
Okay, so TOH is intense edema that resolves. Then there's subchondral insufficiency fracture, SIF. It sounds similar to stress fracture.
It is similar in that it's a fracture, but SEF specifically refers to a fracture occurring in weakened bone, usually due to osteoporosis or osteopenia, often in older adults, especially women. It happens with normal physiological stress, not necessarily overuse. Like TOH, it causes sudden severe hip pain. On MRI, you see extensive BME, but you also usually see a distinct fracture line right under the cartilage.
Okay. Now, this sounds like it could look a lot like the crescent sign in AVN. How do you tell SIF apart from AVN with a subchondral fracture?
This is a critical distinction, and MRI is key. The fracture line in SIF is typically irregular, maybe discontinuous, and crucially, it tends to be convex towards the joint surface. It bulges outward slightly, following the curve of the femoral head. In contrast, the band-like demarcation in AVN, or the crescent sign fracture within it, is usually smoother, more continuous, low signal on all sequences, and typically concave towards the joint surface it curves inward. That shape difference is subtle but vital.
Wow. Convex versus concave. That's a really fine point for diagnosis. Okay, what else is on the mimic list?
Lastly, you have to consider infection, like septic arthritis or osteomyelitis, and inflammatory arthritis, like rheumatoid arthritis or ankylosing spondylitis. With these conditions, MRI often shows signs of joint inflammation, synovial effusion, excess fluid in the joint, synovial hypertrophy, thickening of the joint lining, and often edema in the surrounding soft tissues.
And the edema pattern.
Crucially, in infection and inflammatory arthritis, the bone marrow edema is often seen on both sides of the joint in the femoral head and in the acetabulum, the hip socket. This kissing lesion pattern is less common in early AVN, which usually starts just in the femoral head. Also, you typically don't see that characteristic T1 dark band or the double line sign of AVN in these infectious or inflammatory conditions. The overall pattern looks different.
Okay, so differentiating these mimics really hinges on those specific MRI features: the AVN band, the double line sign, the shape of fracture lines, and the pattern of edema.
Exactly. Careful MRI analysis is usually the key to sorting them out.
This has been incredibly informative. Let's try to boil it down. What are the absolute core nuggets of knowledge that you, the listener, should really take away from this deep dive on AVN?
Okay, first, AVN and bone infarcts both are ischemic bone death, but location matters. AVN is typically subchondral, right near the joint surface, while infarcts are usually deeper, medullary.
Second, X-rays are often normal early on. Don't rely on them alone. MRI is definitely the go-to imaging modality for early detection, staging, the works.
Third, know those hallmark MRI signs, that geographic lesion shape, the serpentine border, the reactive interface line, the famous double line sign, and signs of osteochondral fragmentation.
Fourth, prominent bone marrow edema, especially extending down the femoral neck, or lots of fluid in the hip joint. Those are often warning signs of impending or early collapse. Pay attention to BME.
Fifth, how much the subchondral bone plate, the bone right under the cartilage, has already depressed or collapsed is a major predictor of how things will progress. Size and collapse matter.
Sixth, always check the opposite hip. Bilateral involvement is common, around 50%. And if you see it in multiple joints, 3 or more, think systemic causes.
Seventh, remember the symptom overlap with back pain. Screening the hips during a lumbar spine MRI isn't a bad idea. You might catch AVN, incidentally.
And finally, there are many classification systems, but focus on the findings that actually change treatment. FIANA-RAL is widely used, and adding quantification, like the percentage involved, is really helpful.
You know, looking closely at AVN like this really reminds you how interconnected everything in the body is. Something as basic as blood supply dictates the health of our bones or joints. And what seems like just straightforward hip pain could actually be a signpost, a window into much broader health issues going on systemically.
It really does make you think, doesn't it, how vital that early detection is, not just for saving the hip, potentially, but maybe for uncovering something else entirely that needs attention. It makes you wonder, what other common symptoms might be hiding deeper stories? What else are we missing? We hope this deep dive into avascular necrosis of the femoral head and its mimics has armed you with some valuable knowledge and perspective. Thanks for joining us today.